And one of the committees is like, well, the tax and da da da. And I'm like, literally, we would not spend any more money. In fact, we would save money instantly by giving people access to quality primary care. It's ridiculous that if you actually had codes for prevention, and that's what the insurance paid for, then we wouldn't have sick codes where people are dying of diseases that could have been addressed or prevented with lifestyle medicine, medications, whatever it takes. But these things could have been addressed earlier.
Welcome to Personalized by Vitamin Lab, the show where we dive deep into the world of personalization in healthcare. I'm your host, Dr. David Dizer. Please remember that the following discussion is for educational purposes only and is not intended to diagnose or treat any disease. Speak with your healthcare practitioner first before integrating anything that you learned today. Join us as we explore the remarkable stories, breakthroughs, and possibilities that come with the pursuit of personalized healthcare. Welcome back to Personalized by Vitamin Lab. I'm your host, Dr. David Dizer, and today we're thrilled to have Dr. Maryal Concepcion, a board-certified rural family physician serving Northern California. Dr. Concepcion is the founder of Big Trees MD, a direct primary care clinic that redefines healthcare by putting patients and doctors back in charge of medical decisions. No insurance middlemen. Passionate about full-scope care, she provides everything from newborn and pregnancy care to procedures for patients of all ages. Dr. Concepcion's also the creator of My DPC Story, a podcast ranked among the top 0.15% globally, celebrating the power of personalized, patient-first care. Get ready for an inspiring conversation about healthcare reimagined. Enjoy our show with Dr. Maryal Concepcion. Welcome back to Personalized. I'm your host, Dr. David Dizer, and I'm here with Dr. Maryal Concepcion. Maryal, nice to meet you.
Nice to meet you too, David. Thanks for having me on.
Oh, well, thanks for coming. I mean, I'm just so thrilled to be able to speak with you today because you got such a cool model of practice that I need to learn more about. So we'll dive deep into that today, but we were having a pre-chat and you were telling me about your coffee mug. Tell me a bit more about this coffee mug because I'm drinking out of this Christmas gift. But it sounded like you got a better Christmas gift than I did. Tell me about yours.
Yeah, and it actually was a Christmas gift. So I don't actually drink coffee. It's like methamphetamines for my body, even though I've never had methamphetamines either. But I do love a tea. So Zojirushi is this Japanese brand that makes a thermos. And what I love about it is it gave me an option to have a PFAS-free mug or thermos in this case that keeps my drink at the temperature I want it to be at. So if I put a cold drink or a hot drink, it will keep it hot. And sometimes I forget that it is hot. And then I'm like, oh my God, it's still hot from this morning. So I'm a big fan. Yeah.
Oh, that sounds awesome. Yeah. These pollutants that we're exposed to, it's scaring the heck out of me. For some reason, just recently, there's been an uptick in my practice of like measuring environmental pollutants because I think people are getting more in tune. And I just don't have the resources to help people learn about how to shape their lifestyle appropriately. Is this something that you deal with in practice? Like you talked about this at all?
So yes and no. I definitely would say it's not the most common thing that we talk about in our practice,
Me
but
either.
absolutely with more people being aware, I have gotten more questions about like, hey, like, is there any issue with? I mean,
Right.
How many, recall or messages do we get about like, now there's, listeria or salmonella or whatever. And so I think people are just more aware of that they can't just rely on safety is being done for them.
Mm-hmm. Good point. You really can't rely on, like, one thing I really love about your practice and what you were telling me about the way that you practice medicine is that you're focused on helping people develop their lifestyles to be easy and efficient. And part of the thing I struggle with is helping people, shape their sleeping habits and shape their exposures in real life, in city life, for example, to be as healthy as possible. And we consider this show to be sort of like continuing education, and we try to help people who are practitioners leave with like some tools that they can share with their community quite quickly. What would you say are kind of the go-tos you have for lifestyle design that you'd like to share with a large group of people, like everybody?
So I think that, when I look at it from the physician side of things in terms of how I most effectively talk with people, I really bring how I'm talking in a conversation down to the relatable level of whatever that is. That could be a person who works for Caltrans. I'm in California, so the people who help with our infrastructure and maintaining the roadways, keeping us safe there. The person who works for Caltrans on a night shift is going to be a different conversation than a person who is retired and is basically diurnal. They don't spend time awake doing activities at nighttime. Just having that piece in place really helps me frame and pivot to whatever comes out of, my patients' mouths, because I'm a family practice doctor. And so, I never know if like the appointment is for hypertension, but somebody just lost their pet, like it turns into a grief conversation and I have to be able to pivot. And so for me, I'm always operating out of who is my patient? What do I know about them coming to the table? What do I know about their level of, interest in preventative medicine, hesitancy to do preventative medicine, overwhelm with preventative medicine. And I take it from there. It's a very general piece of advice, but I find that is something where, like at Creighton in medical school, we were taught about the art of medicine. And to me, that's where I am able to bring that relationship to the forefront with my patients and work from there. And then when it comes to lifestyle in particular, like I'm not ACLM board certified or anything, but in terms of like primary care, we deal with lifestyle medicine things every day, whether we like to say it or not. The things that make so much sense to people are even more streamlined when you break it down into things like sleep, the things you put in your mouth, the exercise that you participate in with your body. And so I think that these concepts are they're really familiar to our patients in general, but it's just how they're presented matters.
Good point. How do you develop these relationships? Like you start with this, like personalizing your care. I love it. I mean, how did the relationships develop over time?
Yeah, I think that absolutely time is a component to it. When my husband, who is the other physician at my practice, and I started working in our town of Arnold, California, we started out right out of residency. Well, for me, he had been practicing 2 years, I believe, before we both moved up here. But we were at a corporate clinic, where it was very, very like stark. The husbands went to Dr. Philo and the wives went to myself in terms of our patient panels. And so from the get-go, there were definitely the people who were like, you're young enough to be my granddaughter. And I'm like, I'm just Filipino. I may look younger than I am, but I actually do have education behind my degree. But when it comes to the relationships, how I've always operated, and I think this is where Creighton, I was very grateful to be part of a education center where they really brought out you and they really celebrated you as the person who is also a doctor. And so for me, like I just showed up on day one, even at our corporate practice with, hey, I'm Dr. Concepcion, like tell me about yourself. Like I was never one to say like, I have some people who call me Maryal. And I'm like, you are old enough to be my grandparents, so I really don't take offense if you call me Maryal. But I think that overall, one, just speaking to people like I would want to be spoken to. Two, being able to say like, I actually don't know the answer to that. I'm going to look it up and then get back to you. And then three, having a small town and word of mouth travels fast here. Those things really impacted, our ability to open. I opened independently, and then my husband joined me about 2 years in, to independently open a practice in the same town where we were previously under fee-for-service, the insurance-based system.
Right. You must be making a huge splash. How big is the town?
Yeah. So the town, on the population sign, I think it says like 3,800, but definitely during the pandemic, most of the houses that had been sitting vacant for sale for like a decade or more, they all got bought up. And so there's a lot of people who are half-timers, or they have cabins here for their, time away from the city. But I would say solidly probably around 4,000 to 6,000 maybe since the pandemic. But the population on the sign says 3,800.
Right. Oh, that's really cool. I mean, a husband and wife team in the same town with your own clinic, that must be great. What's it like? What's the lifestyle like for you?
Yeah, well, I will say there's a huge shift in the lifestyle since we went into our own primary care practice. Our practice was initially at a fee-for-service clinic where we had a job share. So for those people who are not aware, we were not aware until residency what a job share was. So together we worked a full-time equivalent. And so we would work 2.5 days a piece. So I would work 2 full days and then a half day, and then he would come in the afternoon and work the remaining 2 days of the week. And we were definitely ships passing in the night when we had that schedule. We had our first son, he was born in 2017, so 2 years into our practice in fee-for-service, we had our first child. And intentionally, we had experiences with our attendings in medical school and residency where attendings, like, they totally practiced in states far away from their own families. Some didn't even know how old their kids were. And we, looked at our goals in life as a couple, and wanting to be parents in the future does not revolve around an 8-to-5 job. So I've never held an 8-to-5 job after residency by choice. And so even though with 2.5 days, you would think like, oh, you have time to like go to the thrift store and like, do crafts and stuff. No, like it was absolutely like draining to do 2.5 days and then like maybe come up for a breath, maybe get sleep on a regular schedule. So when we transferred to direct primary care, it's been completely different because our clinic schedule and even our patient panel size is based on what we are comfortable with and what our lifestyle is telling us. Like, yes, you can take, another patient or 2 patients, whatever it is, and still be able to make the, I joke about this frequently, but it's like, literally, this is what happens to make the fashion show at the elementary school that they tell you about like 2 days before it happens. So if we worked an 8-to-5 job, there was no way that we could have been flexible enough to be like, hey, my kid is performing, I gotta go. Yeah.
Now you can. Tell me about this model. You've mentioned the name of the model a few times, direct primary care. Can you tell me about this model? I need to learn more.
Absolutely. So direct primary care, if you really think about it, is, if you zoom out rather, is old school medicine. So it's literally like before we had a ton of specialists, we had, who do you call if you're, in a town, in a city, whatever, you call your family doctor. And so that's really what direct primary care is at its core. Direct primary care, though, in 2025 is a business model. So it's not only for primary care, but it is a business model where the physician is able to directly contract with their patients. So we work for our patients. It's very different than the concierge model because concierge still dips into insurance, plus they have an access fee. And so we, the traditional pure, quote unquote, pure DPC does not take any insurance. Now, I say that because there are some hybrids, some people who do take Medicare, but not the other private payers. But direct primary care is literally old school medicine with the ability to use the tech that we need to get the job done in 2025. So there are people who are DPC physicians who still do C-sections. There are DPC doctors out there who do cash pay surgeries. Majority of the direct primary care movement is going to be in primary care. But absolutely, you have people who are specialists who are doing this as a business model as well, because they're able to directly contract with their patients.
And do patients sign up for with a yearly fee? How does your fee structure work?
Yeah, so every clinic is different. We have this phrase in DPC, if you've seen one DPC, you've seen one DPC.
Right.
And that is, it does really hold true because you have people who, like our clinic, Big Trees MD, we tier our pricing by age because we expect that as a person grows older, they're going to have more chronic care diagnoses and treatments needed. When it comes to DPC as a whole, the typical way of doing DPC is a monthly membership charge. And then there is, in some clinics, like in our clinic, an annual option that takes, I think it's like 10% off the overall annual rate if you pay it up front. But majority of practices under the DPC business model are doing a month-to-month membership.
And so how does it work? Is it unlimited consultations? Is it a certain number of consultations? How do you police that?
Yeah, so this is where it really depends on the DPC, and this is where it's so unique and really able to fit into a physician's life and their livelihood rather than the physician having to fit into the schedule that corporate medicine double books and triple books on their schedule without their knowledge. So when it comes to DPC, the DPC model is such that a person can determine what is included. Now, for example, my practice, I have most of my care is delivered virtually. Patient portal or a telephone call or Zoom call video chat on a HIPAA compliant platform that allows us to really use the clinic space and in-person visits for when an exam is actually needed. And so, when we're doing lab reviews, what did your normal mammogram say? Like those types of things, I don't have to generate codes and make a person come into clinic so that I can get a code and get paid cents on the dollar to be able to get that information to my patient. Now, I'm able to say, without having to have a conversation with them, unless they have questions, absolutely, then we can have a conversation. But like if a normal mammogram comes in, hey, your mammogram's normal. We've set a scheduled reminder for your mammogram order to be sent out for next year, whatever it is.
There's no extra admin work.
Yeah. And so it really allows a person to craft their clinic in terms of like if a person loves texting, you can do that. If a person wants to see everybody in person, they can do that. So the physician gets to really design their clinic to how it meets their needs. And this is also how, like, overall, right now, DPC, a full panel is like an 8 to 5 job, and DPC is like 600 to 800 patients per person in a panel. And so if you're thinking about like, oh, if I only have 600 to 800, which is a lot of people, you can actually offer appointments same or next day to your patients, because if you have a 4,000 person panel in corporate medicine and your patients are getting mad at you because you can't offer them same or next day care, like the numbers don't work to allow that to happen. And so the model becomes sustainable because it allows the doctor to take care of themselves versus, again, like just being at the mercy of their employer and what their employer schedules. So even just how care is delivered, typically you will have unlimited, visits, but some people, they will set limits to like, I only work 8 to 5. If you need something after hours, like know when you sign up that is not where I come in. You have to go to urgent care, ER still. And some people, they are able to work around the clock. And so it definitely depends on the doctor.
Yeah, that makes total sense. I mean, I think it's a really, really cool concept. So here, it's not popular in Vancouver for naturopaths because people in Canada are so used to having their care for free.
Oh, yeah.
And so basically, the model here for us is very much insurance driven because there's such great coverage for our profession in our province. And I've been thinking about your model and how great that would be to be able to have a specific group of people who really want to be there with you each month. But it's such a challenge to navigate these financial things. It's so difficult. But I hear in your country that it's such a challenge with the billing codes and things. And what will be paid for, it can be such a mess.
I love that, even though like we're in 2 different countries. So my cousin is in BC and then I have another cousin in Aurelia. And so like I've heard, and my cousin in Aurelia is, she's very familiar with hospital administration and just the healthcare system in general. And, the stories that I've heard are like, they are what they are in terms of like people being, so like, oh, we can never do socialized medicine in the US. But I do think that there is always going to be a need for privatized care at some level, because where I think what makes people focus on this, like, oh, you'll have to wait for surgery for a year, in Canada or anywhere else with socialized medicine. I think the concern is that they are so latched on to like, is there another option? Even if someone wishes to pay for it, is there another option? And they don't necessarily think about like, how could that be open to people so that there is excellent quality primary care, especially because that's what affects us the most on the day-to-day. But also if you needed something and, the insurance was not approving it or covering it, what do you have other options? And I think this is where DPC could absolutely be a great fit for Canada, especially because say, for example, if you needed imaging, like say you needed a mammogram in the DPC space can be looked at the wholesale price of the actual imaging. And so a mammogram is $200, 3D mammo, and that's it. Like if you are getting, we won't do another mammogram if you're having symptoms or it's too early, but I know you want a mammogram, like, and we won't cover it. Like that's what I hear, from experiences with my cousins and the stories that they've told me from, their friends and their neighbors and whatnot. Like collectively, the stories that I'm hearing from them are like, we can't get an option though. Like we would love to have the option of like, that's cool if our Canadian insurance will not cover it, but can we at least pay cash to get these procedures done? And again, we're not talking like when I take a mole off of a person's body, like if they're worried about skin cancer, it's like $30 that's what I charge for like lidocaine and the suture and all this stuff. But like that is very reasonable, even if you're like, somebody who has
Definitely.
quote unquote a blue collar job. Like there's this one person that I've interviewed on my own podcast about direct primary care, Dr. Stephanie Phillips. She's in one of the poorest regions of Georgia, and her patient panel absolutely pays her to be their doctor because they know that one visit to the emergency room, the cost for one visit to the emergency room will put them out more money than a year of having a personal physician.
Makes sense.
And then when you have on the physician side, patients at a certain number paying a monthly membership, and you don't have to worry about, oh, if I don't have as many codes as I did last month, I won't make as much. Mm-hmm. And you don't have that stress. You have one more way of focusing on being a doctor and not worrying about codes.
Yeah, that's a great point. Lots of things brought up there. I'll comment on the Canadian thing, the Canadian aspect of it first, because it's important to me. And that's that we're in this situation in British Columbia where we've been said to be able to practice primary care, which is valuable for our patients who need prescription refills, for example. However, in order to run labs and images, we have to pay for them. But the costs of these things here are much higher, my understanding, than compared to private pay in other regions. So, for example, when we refer for an ultrasound, patients have to pay for it. And it's $500.
Yeah.
And then on the physician side, for the ones that are covered for the physicians who are covered by the government, the medical physicians, they are in significant number, are in suits with the provinces currently for practicing private pay on some days. Like having private pay Wednesdays, where the surgeons have a day where they do private pay, and it's not going to be allowed. My understanding is that it won't be permitted. Mm-hmm. And then they move to the States.
And even BC, it's just a ferry right away. Like I've taken that ferry personally, and it's like literally taking a ferry boat down and driving to somewhere in Seattle and getting cash pay options. Like how insulting is that? So it definitely behooves someone to even think innovatively when it comes to accessing care in another country, which is just crazy to me that that could make sense for some people.
Mm-hmm. Completely. Like we'd like to work with the nurse practitioners and the family docs around, and we think that there's going to be opportunities in the future for this. Mm-hmm. And so I'll be taking your model very seriously because I think that it's such a success, and it's such a great way to build a community too.
Yes.
And it sounds like you're building a community of physicians with your podcast. Tell me about, it's the DPC podcast?
Yeah, so the podcast is called My DPC Story for Direct Primary Care. So you and the listeners will probably like to hear this story. I was almost 6 years into practicing in the fee-for-service model, and I got a letter that said that we were going from salary to RVU, which is relative value unit. So basically, if I see anybody in a fee-for-service model, they are assigned a diagnosis like hypertension, and then there is an RVU associated with the code for the visit. So like if I spend 25 minutes with a person with all of these codes for these ICD-10 codes for diagnoses, and the time I spent though, even though I talked about hypertension and diabetes and da-da-da, if I spend so much time, that equates to a payment code, an RVU code. And that RVU code isn't just like, this is how much it's worth, like this is how much bread is worth at the market. It's like, this is what the company is saying your RVU is worth. So for example, CMS, the Center for Medicaid and Medicare, they had increased the rates of payment for primary care, but the local corporation can then take their share and say, yes, we're only paying you this RVU rate of whatever. And so that RVU rate is like, it's literally a way for, the racketeering to go on, because you don't know as a physician who's burned out to a crisp if the doctor down the hall is being paid the same RVU rate as you. If the male physicians are being paid the same amount as you as a female physician. And like, with my husband and myself, we were paid the same. Like, we showed each other's contracts to each other. But when it comes to overall, this is how ridiculous the RVU system is. And just again, going back to how messed up is that like, I am working to bring in as many codes, whether or not it's needed, so that I can make an income. Like, it's terrible. But yeah, so going back to my story, my podcast, My DPC Story, is not about my DPC story. It's about the DPC stories of the guests who share, the physicians who share their stories. Yeah. And I was almost 6 years into practicing in my fee-for-service job when I was told, you're going to go from salary to RVU. And basically the gist is like, treat people more like cattle than humans, because you got to see more per hour, et cetera, et cetera. Your rates for your RVUs are never going to be renegotiated. We have a lovely evergreen contract for you. BS, BS, BS. This thing was chock full of BS. Or we're going to fire you in 31 days. Aww. And I was like 28 weeks pregnant with my second child and worried that as a physician, what am I going to have, Medi-Cal? Like, am I not going to have access to my doctor because my doctor doesn't take Medi-Cal, my obstetric doctor? And so it came out of righteous rage and like insomnia and just all of the feelings of like, I cannot believe that this is happening to a physician, and the only female physician to this day still who you can see if you're pregnant in this county. They don't want you. They don't need you. They don't care about the level of quality care that you're bringing. They just need a coder. And so I, pregnant as all get out, sat on my bathroom floor at 2:45 in the morning and like never done a podcast before. Googled how do you do it, created a logo on Canva, and then it's blossomed into this platform where I heal every time I talk with a DPC doctor, because I'm like, I love that there's more of us out there. And I am so like, just so jazzed by being able to be speaking and highlighting these physicians who are sharing their DPC stories so that it inspires more people down the line. And I think that this is how we change American healthcare. I'm very passionate about telling everybody that I can about DPC.
Definitely. Tell me about some of the stories. I'm sure you've heard some similar stories from these physicians. Tell me about some of the stories you've heard on your own show.
Yeah. So like one that I love quoting is a doctor said that she was just not going to be okay with her schedule being double booked, triple booked. And the administrator said, well, we don't trust physicians to determine their own schedule. But you trust physicians with doing healthcare and saving lives. Like, that's cool, right? That's cool. And then you have people who, and this was just so selfish. You have a person who is leaving their practice to be able to practice under the direct primary care model. And there was a non-compete radius. So basically, if that person left, the doctor could not practice within like 10.1 miles from the previous practice. And it's like, how does that help patients, right? Like, if a person has continued with you your whole career or their whole time with a primary care doctor, and then that person is not allowed to practice because some contract says so. I mean, it's just ridiculous stuff like that. But then you have so many stories of like how they were poorly treated by the system. This person hasn't been on the podcast, but I met a pediatrician who said to me that the day that he knew he was done was when he had his colleagues call in sick, and he had 80 patients on his panel in one day. And one of the babies coded on him in the clinic. And he was like, nope, I'm done. I'm out. Yeah. And so, it's just, it's so, I think it just goes back to like the humanity that is supposed to be like paired with healthcare. Yes, we are a business in terms of direct primary care is a business model, but we're having a business to align with our mission. Not we're having a business to bankrupt every single American or, in our case, and so that people can't even get basic human care, healthcare, and they can't like get it or they go into bankruptcy or they just don't deal with it because it's too expensive to actually try to figure something out. Because like an ultrasound does not cost $500. A complete blood count does not cost $47. A thyroid TSH does not cost $200. And so we're bringing a business model that is for everyday Americans.
Vitamin Lab revolutionizes personalized supplements, empowering health practitioners to create tailored supplement formulations that address each patient's unique needs. Bring personalized health to your practice and choose from over 200 professional-grade ingredients to create vitamin formulas that improve patient adherence and result in tangible outcomes. All ingredients are sourced from the world's most trusted suppliers, and Vitamin Lab provides hands-on support to help you formulate and launch personalization to your patients. Say hello to a new era of personalized supplement solutions. Go to getvitaminlab.com/personalized to save $100 off your first formula.
Oh, yes, you really are. Wow. Okay. Well, the passion is felt, my friend. Good for you. Holy, it must be inspiring to go to work every day when you've got these stories behind you that you're constantly updating as well with having your own show.
Yes.
That also must be a nice driver too. Not only the patient success stories. I mean, I think about this model in like the old school way of doing medicine, like having a bag of coins dropped at your door for all the healthy people that are around. That's what we need. That's what we need. So it sounds like you've got an opportunity to do this prevention and to make your livelihood in doing that and feel excited about going to work every day. How far is too far? I'm writing a paper right now about the economics of disease prevention and trying to think about what is valuable to organizations, for example. How far should we go? Because people come to me and they want to go all the way. They want to live as long as possible and be as healthy as possible. But certain things and certain time spent might not be valuable, even though the podcasters out there and the social media influencers suggest that they are. How far are you going? I just tried to launch an unlimited visit type model because I want to do a similar idea. And I want to follow up with the person every week. Let's do this week, this next week. How do you decide? Like, what is your path there? That's a loaded question.
Well, I think it's a reasonable one too. And I think that this is where time in practice matters, because when I was a medical student, if you had asked me that question, I'd be like, what does the algorithm say? Like, I have no idea. But as a practicing physician, again, this goes back to knowing your patients really adds a level of confidence to say, like, this person does not live with anyone. They're older. I need to follow up with them because I know a snowstorm is coming, etc. Like, there are certain things that weigh on my psyche to drive this. But this is the art of medicine again. Like, when it comes to a person who it's like, hey, we talked about lifestyle things and it's a little bit overwhelming. So let me send you like blogs I've written on the topics that we talked about, links to download, free podcasts for insomnia, whatever it is. And then let me know if, any of these are drumming up questions in your head or whatnot. They're like, for the most part, a lot of patients are like, I give that open invitation to, like, there's no stupid questions here. If you have any question related to your healthcare or the health industry, like if they are having issues navigating their own care beyond our clinic, like with specialty care, imaging coverage, etc., we can help with that. And so it's mostly an open-ended invite for people to follow up. But there's definitely things where it's like, if somebody is acutely sick on a Thursday and it's a Friday, like, we're going to most likely, well, again, it depends on the situation, but if it's a respiratory illness and we know that someone is like, you got asthma, you did okay, but like maybe you're having fevers, we're going to follow up with you tomorrow. And even on the weekend, like, I've checked up on people, especially people like, I have a patient who has dementia, and like that person, if they're out of the emergency room, like, I don't know what's gone on in the last 24 hours. But I get paid to be a doctor. I don't get paid to process codes anymore. And so anything that I do, I know that, like, hey, this is just me being me, and I'm working for my patients. So it's, that time to follow up or how you follow up is really individualized.
Yeah, that makes total sense. And it also seems like beyond just the coding that your operations may be streamlined a little further. Can you talk about your operations and how this model might facilitate an easier, maybe not easier, but maybe more streamlined approach to running a clinic?
Yeah, I definitely would say that overall, I do think it's easier and it's definitely more lean compared to a fee-for-service clinic, because you don't have to bill, you don't have to code. I mean, you have to bill them, but like, you don't have to bill them for every single visit.
Yes.
And so when it comes to operational overhead as well as the actual workflows. DPC doctors tend to go lean with a low overhead to start. So like myself, I opened as a telemedicine home visit model for the first year. One of my best friends in this movement is exclusively home visit model only, and she has over 150 patients.
Holy, good for her.
In San Diego, yeah. But when it comes to the world of direct primary care, you have electronic health records that are focused on the DPC physician and not how to generate those codes and MIPS and macro reports and whatnot. And so when you have tech that is also helping us do our job, you can do a lot of things like automations, or you can have things that are more streamlined to cut down on the admin needs. Like, some people like an amazing physician in Rhode Island, she has a micro practice that she opened right out of residency, and she's never had staff. And so, it definitely depends on your level of neurodiversity and also how much you can take in terms of running the admin stuff. But it is absolutely possible to keep overhead low, because these SaaS platforms and whatnot that we use can be very affordable compared to, for example, if you used a big EMR, one of the big system EMRs, you could pay $40,000 a year versus $300 to $400 a month with a DPC EMR. You also have on the workflow side of things, you're literally working for your patients. So especially in primary care, and yes, we wear a lot of hats because we're primary care, but if you know that the most common things like cough, colds, scrape knees, hurt knee, whatever it is, dermatology needs, whatever, you have a streamlined set of things that you are very commonly going to be covering. And so you're able to create, in my EMR, I'm able to create a whole order set. So basically it's if I put in a code, because I do still use codes to track what I'm treating, but that's not a code for insurance billing purposes.
I understand.
I'll use the same ICD-10 codes, like cough. My cough will prompt orders that I can choose from immediately, and a note that is generated from a dot phrase or a macro. And so it literally is because our workflows are able to be as nimble as we are, that we can make our workflows easier than in fee-for-service.
Smart. How long are your visits? Or does it, I guess maybe every visit may vary?
It does. And that is true. But I laugh because typically my visits are no shorter than 45 minutes. Nice. And that could literally be just for even suture removal. Because, when a patient comes in, most of the time, even in DPC, even when they have the ability to, get seen same or next day, they're still Dr. C, I've been meaning to ask you about. And so and yes, you have boundaries. And I have to say sometimes hey, you know what? I'm going to write this down. Is this something acute? No. Then I will say hey, let's carve out some time to make sure we have enough time to address this, because I don't want to cut short our discussion, because nobody deserves that. And I want to get you a good answer on whatever it is. So there are ways that I have boundaries even with that. But generally my visits are 45 minutes or more.
Incredible. Very cool.
Yeah.
How does labs and imaging and referrals work for you? Are those things that you bill extra for? And how do you organize that?
Yep. So we have the ability to give our patients options. So say, for example, a person comes in for their annual visit and they need annual labs. So I can say to them, would you like me to bill this to your insurance? I do not know what they will charge you at the end of the day. Or would you like to pay the $65-ish for the exact same set of labs? But so what we do in California, because we can't do pass-through billing, is we bill the patient and the lab bills us. So we just send out the bill to the patient after we get to the cents what we were charged for the lab to draw their blood. When it comes to imaging, we do the same thing. Would you like us to send the cash priced order to the imaging center, or do you want to go through your insurance and have your insurance billed for whatever it is? I had a patient who has a supplemental, so her Medicare insurance plus another insurance to cover what Medicare does not. And that patient still had to pay $400 for a mammogram because I ordered a 3D mammogram and only a 2D mammogram was covered. So the patient, though, typically, especially with our culture being so tied to insurance as healthcare, that mantra, they're like, oh, but I absolutely, I want to bill my insurance. And I get it, because it's like you want to max out what you're paying for.
Completely.
But at the same time, if you don't even know if it's covered, and that is never a transparent answer to get to, my patients do, they like the opportunity to have like, what is the cash price? Like, again, it's like, here's what your insurance world is, and here's the privatized option if you wish to use it. When it comes to referrals, it's the same in fee-for-service as it is DPC. We, see our patients, we send our notes over, EKGs over, whatever it is, and then we just send the patient packet over with their insurance information. And the specialist typically, if they take insurance, will just bill like they would normally a regular referral. Yeah.
Okay, that makes sense.
Mm-hmm.
Well, thank you for sharing all the details of that. I know I'm totally new to the model, so I had to go all in. I really appreciate that. Let's talk about your typical day. I know that it sounds quite varied, but if you could share with us some of the main things that you're helping people with, and maybe a little bit about your approach to these. Like, what would be the number 1 and 2 items that come across your desk, concerns that patients have?
Yeah, I would say, like everything related to cardiac health is probably a big one. And we know, at least in the United States, cardiac disease kills more people than all cancers combined. So to me, it makes sense that, people with anything cardiovascular, so hypertension, high cholesterol, diabetes, those types of things are definitely up there. And then I would say probably the next one after that is just the bread and butter acute things that we see in family medicine, like coughs, colds, etc. So in answering your question about how do I approach these things, I definitely would say, one, I write my notes for me now. I don't write them for the insurance company.
Yes.
And so I will write my notes so that my future self is like, remember, they said that they were going to try this intervention, or that you said that you were going to do whatever. And just opening the conversation from there is typically where I start. When it comes to interventions, like if we're, monitoring labs to be able to like decide, is a prescription medication reasonable? What are the pros and cons about that? Whatever. If that is determined by monitoring labs, I'll try to get labs, in the EMR and reviewed before I see them. That is something that we are really working towards, to get labs done before a person comes, because we're going to need them anyways. And then also when it comes to acute things like UTIs, that's a good one. Making sure we know, like, how many UTIs does this person have this year? Like, it could be 0, it could be 4. And so, that helps guide our treatment differently in that case. But yeah, I would say that the approach is really, even with what we know about our patients without having to even open our electronic medical record, there's still things that I write to my future self that I am in the habit of looking at before I start seeing the patient for a new visit.
Yeah, I like that. And I like what you mentioned about having labs before a person comes in. I know there's a lot of clinics around who, that's what they do. They have a panel of things that they require before the first visit. And they somehow have that structured so that can happen and communicate it effectively. Like, here's what we're doing and here's why. And at our clinic, we start with this. And I admire that. And I think that could be very valuable. We try and do a few things in office in the first visit to try to, grab some objective data, but it can be also a challenge to even communicate the need to spend that time and resources. So the lab conversation is always so helpful. It's difficult to communicate. The communication piece can be a real challenge, especially around cardiovascular disease, where everyone is so focused on blood pressure and cholesterol. Yeah. It can be difficult. But thinking about building that holistic approach out, what else can we consider for this person? Because in Canada, it's the same issue. It's cardiovascular disease. And my family goes through it. Every family I know goes through it. And in fact, now we're seeing issues with younger people here. I don't know if that's occurring in your region as well, but like since the pandemic, obviously. But what else should we be considering from a primary care perspective as this holistic approach is built out in cardiovascular disease risk reduction?
I think that the difference that I see in our DPC practice compared to fee-for-service is just how we present the data to the patient in terms of what is their cardiovascular status. I mean, I am not a person who puts any reliability marker on an in-person, in-clinic blood pressure. Like, I never diagnose a person on that, and I saw that too often in fee-for-service. But going beyond that, for me, a more holistic picture that I am able to bring to our patients is we have a VO2 max machine in our clinic.
Nice.
We do charge a fee for that because we have to pay to have this machine in our clinic, but then also doing and talking with them about doing a more in-depth panel. So for example, we're able to look at not just the traditional lipid panel, but we're able to look at like, what's your inflammation marker? What's your LPLA, I'm not saying that correctly, but basically like your breakdown of your LDLs, your more comprehensive panel to show like what type of cholesterol are you preferentially making, what's your inflammatory level, and then to me, that has really opened up the gate to talk about sleep, to talk about everybody who's an adult needs a sleep study, period. Like that's 100% my opinion, because everyone's like, oh, I feel rested. I'm like, but what do you have to compare to? Like, yeah, you might have like a stressful night, restless night, whatever. But like, do you actually know what you're doing? And, you know, if we're able to detect sleep apnea with an Apple Watch or whatever, fantastic. But I do think that every adult needs to have their sleep studied in an effort for quality sleep. And also like, what happens down the line if like, oh, atrial fibrillation hit you like a ton of bricks? Like you could have maybe seen that coming because of history as well as a test. Talking about exercise and being physically active. And even right now, talking about like when you talk about how Canada is seeing similar things, especially in younger people, like in America, our obesity rates are insane. I mean, like 70% of people are obese, or excuse me, are overweight. And I mean, that is so much tied to lifestyle, but it's also tied to just our culture of processed foods and all of these things. And so when I'm talking with my patients, there definitely have been conversations lately with, you know, like, do we need to entertain a GLP-1 if lifestyle habits are not making inroads and we're seeing things like hypertension or high cholesterol or prediabetes or diabetes on the table? That's something I never had to talk about in medical school because we didn't have GLP-1s. But when it comes to my patients, I talk with them holistically, really in the sense that I'm talking to them about, here are all the options, for whether that be for more conservative to, you know, actual treatment with medications and everything in between. And I think that it's really helpful for our patients to know that they don't have to wait 6 months to talk to me about, hey, I was able to try this one intervention and it did or did not work. Like I literally sent a message this morning to my patient. How has that medicine been going for you? Like she didn't tell me anything. I know that, again, going back to like how much is too much. I'm like, you are on a new medication and you are not a person who takes meds, and it's a month later. So how are you doing on it?
Yeah, that's so nice that you can check in. But this holistic approach is just golden for me. How can we bring this to all Canadians where we're also talking about, instead of just blood pressure and cholesterol, sleep and weight and VO2 max and inflammation at the same time with your ability to check in every month? This is what we need. We need a system where we can do this for everybody. Yeah. And it really sounds like this system could work. And what I need to study, what I would like to study is like, if we had a successful system like this, how much money would it save people? Right? It sounds like it'd be very cost effective.
And this is what I think is the most insulting thing, like, about American healthcare in terms of like how I'm relating things and picturing things right now in my head, is that, you know, I am on a set of committees, and one of the committees is like, well, you know, the tax and da-da-da. And I'm like, literally, we would not spend any more money. In fact, we would save money instantly by giving people access to quality primary care. And again, I'm speaking from the primary care world, not DPC as a business model.
Yep.
But like, it's ridiculous that if you actually had codes for prevention, and that's what the insurance paid for, then we wouldn't have sick codes where people are dying of diseases that could have been addressed or prevented with lifestyle medicine, medications, whatever it takes. But like, these things could have been addressed earlier. And I mean, this is stuff where, like, say for example, I have a patient in their 90s, and they have kidney issues. And if they did not have a doctor to bounce any question off of, this person's partner was like, hey, can I do this like whey protein powder because they're losing weight? And I was like, hold on a second, we got renal things to think about. We got congestive heart failure issues. We got things to think about. We can't just throw protein left and right. But it's like, this is the type of stuff that if he had not had this answer, this conversation, could he have ended up in the emergency room? Possibly. Mm-hmm. And so, it's these things that you need to have a credible, reliable, relationship-based source of someone who is trained to talk with you to be able to get good health care. Mm-hmm. And that is for sure as heck not what is going on in the insurance-driven system in America.
No. And I feel like, I feel like you brought up earlier about the trust, the lack of trust and that there is for healthcare professionals. And I'm just wondering, and I feel like maybe there is a wave that's coming. So basically, I would trust you with my health. I would trust you with helping me to prevent disease, and I would refer people to you for that purpose. But I don't feel like the governments and the insurance companies are putting their trust in people to actually follow something that is rational and evidence-based. And so on these extra 4 pillars, I feel like there's objective markers coming and there'll be AI-driven algorithms that will help companies decide if prevention plans are worth it or not.
Oh, totally. Well, you have, for example, there's a whole section of this country that is, it's 54 to 56%, I believe, of our population that is getting their insurance through their employer. And so this is a huge space where there's a whole summit about this. It's called Rosetta Fest, but there is a whole movement of employers who are waking up to, wait a minute, you're telling me that I actually do have an option to save my employees a ton of money, right, and get them better health care? What is this thing? And so when you have DPC doctors who are like, yeah, that's actually what I do in Indiana, in Oklahoma, in Arkansas, whatever it is. And you have employers who are like, you're telling me that my my employees can access you and get these $200 mammograms, $6 TSH labs, and I don't have to spend as much for every time they go to the emergency room because they could not get into their primary care doctor. It completely makes business sense. And so you have a huge portion of even unionized groups are going towards a self-funded plan. That's what we call it here in the States, where you're getting a catastrophic plan to back up for catastrophic events. But in terms of your everyday primary care, it can be handled by an independent direct primary care physician.
I love it. Mm-hmm. I love that. We just opened up a space that's kind of in the center between Apple and Microsoft and Deloitte and Amazon. And we would like to be able to show them that enhancing VO2 max and having a low body fat percentage is going to save them money in the long run.
Yep.
This is what we and your team of DPC could do that straight across America. That would be incredible. Yeah. That would be amazing. We have to prove the research has already been done. Primary prevention works and it saves money. This change, this shift is going to be a challenge, but it's a worthy one to take up.
It totally is. And especially from the employer perspective, you think about healthier employees, happier employees, because they're not stressed out because they, had to, basic things like had to get childcare in order to go to the doctor. And then they had to pay the babysitter extra because the doctor was running behind. And then you have the people who are like, and I still didn't get it covered, even though I have insurance through my employer. And now I'm also facing bankruptcy while I show up to work. And then you have the facts that a person who has quality primary care access is going to live longer. There's your employee working for you longer potentially. So it's like you zoom out and it makes so much sense. And, it is so wonderful to be part of this movement because literally we are able to, I have people on my podcast who've opened right out of residency to literally be able to take care of a person like I'm describing here.
I love it. Amazing. Yeah. One thing we typically ask on the show is like, what would you tell your younger self? What would you tell yourself right out of school? I feel like I know where this is going. But tell me, what kind of advice would you give yourself straight out of residency?
Yeah. I think for me, it really revolves around entrepreneurship. My dad was a master's in social work and worked for a regional care center, looking after care homes to make sure that clients at the care homes with developmental delays were safely taken care of. My mom had an AA degree and worked for the state. Like everybody in Sacramento works for the state. And that's what I came from. And my whole, like my extended family, cousins in Canada, we're all people who are employees. You know, that's our nature. Some of us have become entrepreneurs, but I think that that's one thing that I would have loved to have been exposed to, because I think that that would have made me more confident in my abilities to do everything in life, and also be able to be more business savvy. And so that's what I would have said. And I'm encouraging my sons, you want to start a crayon business, a baking business? Like what do you want to do? Because even if it's just for like a summer, I just think that being an entrepreneur changes your mindset so much, and it empowers you also to do good things for others, which I think is so awesome. Like when you are able to tie your finances with your mission, that's amazing.
Definitely. It had such a negative connotation when I was growing up in the East Coast of Canada, because I think it was just driven by movie culture, talking about used car salesmen and how awful they terrible they were in movies. I knew some in real life and they're great, but the culture was so much against entrepreneurship. And now with the healthcare entrepreneur, it's becoming iffy again because of pushing the boundaries of evidence-based approaches. But I am fully with you. And most of the people who are in naturopathic education here in Canada feel the same way, that we need to open this up for our graduates and teach them how to effectively get their mission out, get the vision for their clinic established, and to help as many people as possible. Look at you, you're doing it.
And I think it's so important, especially for the younger generations, to know, because as we go into AI in everything, people are people. I was an anthropology major in college, so I know that people are always going to want to have that human connection, no matter how much AI is out there.
We're going to be all right.
Yeah. And I think that is something that I tell people, all the time when they're like, oh, we're going to be replaced by AI. I'm like, I'm not, because like there's only one me out there. And that's what my patients are investing in being members at our practice.
For sure. Well, good for them. Holy smokes. It was very nice to chat with you. Where can more people find out about you online? Where should we look?
Yeah, I would say the main place to learn more about DPC is mydpcstory.com. So there you can connect with us on socials. You can connect with us. We have a newsletter. And just weekly, we have a new physician or a clinic with, like today I interviewed 3 physicians at one clinic who are sharing their DPC story. So it's full, every episode is full of what pushed a person into DPC, but also how they're doing it, business, tools, hacks, etc. So that's my main place to find me, and it's a great place to be.
Very cool. Well, Dr. Concepcion, it's very nice to meet you, and I really look forward to this episode being launched. I'm so grateful for your time.
Thank you for having me. It's great to be here.
I'll chat again soon. Have a good day.
You too.
Bye.
Thanks for joining us for today's discussion. What about today's podcast resonated with you? Be sure to tag at Dr. David Dizer and at Get Vitamin Lab. If you're learning from and enjoying this podcast, please let us know by subscribing to our YouTube channel and follow the show on Spotify and Apple. And don't forget to leave us a review. It's the best way to support our podcast, and it helps others find us. To learn more or book a demo to explore what personalization could do for your practice, please go to www.getvitaminlab.com/personalized.